Good evening, everyone, and thank you for joining us for another edition of the Fifth Avenue Synagogue Sunday night speaker series. I apologize about the lack of video feed, but we're currently at a bat mitzvah, so we just stepped aside to join the program. And Rachel will formally introduce her father, Dr. Storch, but I just wanted to use this opportunity to publicly thank Dr. Storch for all of his time and guidance during this unusual time of our lives. One of the most difficult aspects of going through a difficult experience, a trying experience, is the uncertainty of the matter. Not knowing exactly how to act, what to do, creates a certain anxiety for many people and just makes the challenge so much more difficult to handle. And throughout the pandemic, I think one of the most difficult and challenging elements of it has been the unknown. It was a new illness that emerged on the world scene and created a great amount of anxiety for many of us simply because we did not know how to handle it. And we at the Fifth Avenue Synagogue had the great honor and privilege to have the opportunity to address our questions to Dr. Storch over these past 2 years. He was there for us at the very beginning of the pandemic. He was there for us during the heart of it all. And he's here for us once again today. He is an infectious disease specialist, an expert in his field, who has made himself available to our community and to many individuals as well. I know from firsthand experience that he's an extremely patient individual, highly approachable, and very understanding of people during their time of need and what stress people go through at various times. And he makes himself available for us, all day long. And we are very, very grateful for him. So I want to give a public thank you to Dr. Storch for all his guidance and insights. He is a very busy man, but he made some time for us. It could be that maybe we have some connections to him, some nepotism involved, but whatever it is, we are very, very thankful for his participation and making himself available during this most challenging time in world history. Rachel?
Thank you, Rabbi. Well, I just want to extend a warm welcome to everyone on the Zoom tonight. I'm so grateful to my dad, Dr. Gregory Storch, for taking the time to join us. As those of you who have joined us for prior Zooms with my dad will know, he is a pediatric infectious disease specialist. He holds an endowed chair at Washington University School of Medicine as professor of pediatrics and molecular microbiology. He is also past chief of the divisions of pediatric infectious diseases and pediatric laboratory medicine. Dealing with epidemics is not new for him. He has spent a career passionately examining and dealing with infectious diseases, including some years earlier in his career as an epidemic intelligence service officer for the CDC, and doing some very consequential work in the early stages and throughout the HIV/AIDS epidemic. His career has involved both intense research and clinical care of patients at St. Louis Children's Hospital, with the research and clinical care vitally informing the other. His work was recognized this year as the 2021 recipient of the Distinguished Physician Award from the Pediatric Infectious Disease Society. He also serves as the Research Integrity Officer for WashU. Beyond that, he is also just an amazing father to my siblings and me, and an amazing grandfather to my kids and to my nieces and nephews. And I'm thrilled that we have this extra time together, even if just by Zoom. So, Dad, this is the third or fourth time you have joined our community to speak about COVID. Sadly, it's starting to feel a little bit like Groundhog Day, where a variant arrives, it peaks, it wanes, some level of comfort is reached, and then a new variant arrives and we begin again. Now, 2 years into the pandemic, we are armed with an increasing number of defensive weapons. Tonight, our topic is getting our children vaccinated for COVID-19, what we need to know. So we look forward to hearing from you about the vaccine as it relates to kids. We've also asked that you touch on the new Omicron variant, and then we'll open the program up to questions and answers. And we look forward to hearing from our audience about any questions you might have on these or other COVID-related topics. You may submit your questions through the chat or Q&A functions, and I will then pass them on to my dad. And with that, Dad, go ahead.
Thank you. And thank you to the rabbi for his kind remarks and to Rachel. And I'm very happy to be here. It's my pleasure to try to share information about COVID with Fifth Avenue Synagogue. I'm going to skip this slide very quickly, but I just want to point out one thing on it. And those are the initials after my name, MD. I'm sure you understand, but you may not know what FFAS stands for. You might think it's a scientific society or something like that, but it actually stands for Friend of Fifth Avenue Synagogue. Okay, that's going to be the last anything like a joke that I tell, because we have a serious subject to talk about tonight. And I have just 14 slides that we'll go through that have some general information to get things going. But I'm expecting and hoping that the heart of the evening will be the Q&A session. So I hope some of you have either prepared questions or questions will come to you during the portion while I'm talking, and then we can try to address them. And they can deal with issues related to children and vaccines, but it's okay also if you want to ask questions about other aspects of COVID. So let's see if I can move this slide. Yeah, there we go. So just start with a little bit of vocabulary to make sure everybody's on the same page. So COVID-19, of course, is the disease that we've all become much too familiar with. SARS-CoV-2 is the scientific name for the virus that causes this disease. We'll be talking a lot about vaccines this evening. So a vaccine is something that we give to prevent a disease. It's usually not used to treat a disease. It's used before the person has the disease to try to stimulate their immune system to become immune to the disease. Now, we've also become familiar with mRNA, and that stands for messenger RNA. RNA is an intermediate within our cells between the DNA, our genetic code, and the proteins that DNA directs us to make. And there's a RNA that corresponds to each protein that our bodies make. And we've learned through terrific technology how to synthesize RNA molecules, so we can synthesize RNAs corresponding to any human protein or to any viral protein that we know about. In the case of these vaccines, the protein that we're talking about is the protein called the spike protein of the virus. And we know that if our bodies develop antibodies and other forms of immunity to the spike protein, that will render us immune to the infection. Now, of course, you can't get COVID from a messenger RNA vaccine because it's just a tiny fraction of the whole virus. COVID or SARS-CoV-2 has 29 different proteins. And so this is just one gene that is used in the Pfizer and Moderna vaccines. And it is a remarkable concept that RNA, along with a few other materials, is injected into a person's body, and the cells take up the RNA, and the RNA then goes into this cell machinery and directs it to make the spike protein. And then the immune system of the body recognizes that protein, recognizes it as foreign, and makes antibodies and other responses to it. Now, adenovirus is another respiratory virus, different from COVID, but it has been modified to serve as what's called a vector or a carrier for other genes that can be moved into adenovirus. And the adenovirus itself is crippled in the laboratory so that it itself doesn't make people sick, but people receive an injection of this genetically engineered adenovirus that, in the case of COVID, has the gene for the spike protein engineered into it. And when the adenovirus infects certain cells, which turns out to be harmless, it also causes the S protein, the spike protein, to be produced, and we make an antibody response to it. The Johnson & Johnson vaccine, which is in use in this country, and the AstraZeneca vaccine, which isn't used in this country, are both adenovirus vaccines. So we have the two mRNA vaccines, Pfizer and Moderna, and we have the adenovirus vaccine, Johnson & Johnson. Now, the last line, and the last term, may be one that some but not all people are familiar with. That's MIS-C, and that stands for multisystem inflammatory syndrome in children. And that's an unusual manifestation of COVID that we're going to talk about a little bit later in the talk. Now, just a little update on COVID in New York City. I feel a little bit funny being here in St. Louis and telling you about COVID in New York City. And Rachel tells me that the test sites, when she walks by, are very busy. That probably is an indicator of COVID activity. But as of December 12th, it's remarkable that there were over 1 million cases that had been diagnosed in New York City, more than 34,000 deaths. Very, very tragic. And daily cases these days, the 7-day average is over 2,300. And the last day where there was a report was somewhere about 3,200 cases. Cases are increasing in New York City. Hospitalizations and deaths, which lag, are just starting to rise. And the hope is that because of the effect of vaccination, they will not go up nearly as much as the number of cases. The positive test rate is 3.1%. That's higher than you would like it to be. It's not an astronomical level. And it's a good thing that 78.3% of New Yorkers have been vaccinated. And we can see that vaccine helps a lot. The case rate in New York City is more than 8 times higher in unvaccinated people than in vaccinated people. And the hospitalization rate is more than 13 times higher in unvaccinated people in New York City. So even though the vaccine has limitations and we have to augment it with boosters, it's clear that it helps a great deal, especially with more severe infections, those that result in hospitalization or death. Now, let's turn our focus to children. And I want to try to think about this from the perspective of parents who have to make decisions about their children and vaccination. And so I want to talk about COVID, the disease in children, and then I want to talk about the vaccines in children, because decisions realistically represent weighing alternatives. It's not one or the other. We have to think in terms of different alternative courses of action. And so it is important to have a complete viewpoint. So first question I want to address is how common COVID is in children. You know, early on in the outbreak, there was an idea that COVID really didn't occur very much in children, but that was not really right. It does occur in children. And as the outbreak has proceeded in the United States and in many other countries, children proportionately are contributing more cases than they used to. So now we're up to 22% of reported cases being children. A while back, it was more like 17%. It's a lot of cases. And it's estimated that there were more than 133,000 pediatric cases that were reported just in the past week. Now, it is true that COVID is milder in children than adults, and less than 2% of cases are hospitalized. So of those 133,000, we're only talking about a few thousand, it's still not a small number, but a few thousand who were hospitalized. We know that children of all ages can be affected. I've seen 1-day-old babies with COVID, and I've seen teenagers with COVID. It spans the age range of pediatrics, but it's most common in teens, but it's also quite common in elementary school age children as well. We also see that a disproportionate share of cases are in Black and Hispanic children. Now, it is mild in most cases, but there can be fatalities. And as of December 2nd of this year, 651 US children had died from COVID. And I mentioned that the percent of all cases that are children is increasing. Now, what are the signs and symptoms of COVID? How would you recognize it in a child? I mentioned that it's generally milder than adults. And in fact, somewhere in the range of 15 to 40% of children who are infected have no symptoms at all. They just, if you happen to test them, they would have a positive test, but they would have no symptoms. Of those who do have symptoms, fever, chills, and cough are the most common, and that's really very similar to adults. Other symptoms include headache, sore throat, runny nose, muscle aches, diarrhea, other abdominal symptoms, nausea and vomiting, abdominal pain. We recognize now that some children will have only gastrointestinal symptoms, won't have any respiratory symptoms as their manifestations of COVID. Some will have shortness of breath, and loss of smell or taste can occur in children as well, although the younger children generally won't mention that, but certainly teenagers will become aware And in small infants, we can't recognize a number of the symptoms in that list, but they may present with fever and feeding difficulties. Now, you may look at this list of symptoms and say, but wait a minute, those are just the symptoms of umpteen other viral infections and other infectious diseases. And I would say you're absolutely right. And this is one of the problems that we have with COVID, that many of the symptoms are not particularly distinctive, especially early on. As the disease progresses, you get a kind of characteristic constellation of symptoms. But early on in particular, it can seem like a common cold or other viral respiratory infection. And I've heard numerous instances of people who thought they had a cold, kept going to work or whatever they were doing, and then found out that they had COVID, and a number of people had been exposed. So we have to be cautious about this and recognize that any respiratory or abdominal symptoms, we really have to think about COVID as a possible explanation. Now, I mentioned last time I spoke at Fifth Avenue that among the children who are hospitalized with COVID, it's very common, more than a majority, have one or more coexisting conditions that renders them more susceptible to serious COVID disease. And this is true in adults as well, but it may be even more true in children. The most common one that we see is obesity, and this is often very severe morbid obesity. Metabolic or genetic diseases, including diabetes, congenital heart disease, chronic lung disease of children, neurologic conditions, cancer, other immunosuppressive conditions or treatments, or anything that makes a child so-called medically complex, sets up that child for more severe COVID. This is not unique necessarily to COVID. Many viral infections have that characteristic, that they can be tolerated by a person who's very healthy, but a person who has underlying conditions is more rendered sicker than somebody who's normal. That's very true for COVID. So most of the hospitalized children who have COVID itself have these underlying conditions. Now that may allow you to say, oh, I don't have to worry about that because my child doesn't have any of those conditions. But it is important to recognize that there are plenty of children out there who do have one or more of these conditions. And those are the children who are particularly vulnerable and who we do see in the hospital. So it's definitely a significant presence. Now, here's where we have to have the discussion about multi-system inflammatory syndrome in children. I'm sure some of you are aware of this. It's gotten quite a bit of publicity. And this is another clinical manifestation of COVID, but it's different from acute COVID or the infection itself. MIS-C is probably an abnormal immune response to COVID. And as such, it occurs about a month after the actual COVID infection. That initial infection can either be with or without symptoms. We've had numerous cases in our hospital where a family had COVID, a particular child didn't have COVID, but then a month later, that child became sick with MIS-C. And what's also different about actual COVID is that most of the cases of MIS-C do occur in healthy children. So if you're the parent of a healthy child and you're thinking about how much of a problem or a threat COVID represents to my child, you can think about COVID itself and recognize that that tends to be quite mild in children. Your child will most likely weather it. Small percentage of children do get very sick, even normal children, but most normal children will weather it. But it's also possible that your child can get MIS-C and become very, very sick. And I'll describe that in a few minutes. Now, I don't want to overblow this. It's not terribly common. It's estimated that there have been about 600 or more cases in New York City to date. So it's somewhere in the middle between common and rare. It's certainly something that's out there. We've seen quite a few cases in our hospital in St. Louis. Now, what are the symptoms of MIS-C? Fever, often gastrointestinal symptoms. These children may have a rash. Red eyes can be prominent, swollen lips or tongue. They may have headache, lethargy, confusion. They may have respiratory symptoms. If you're aware of something called Kawasaki disease, you'll see that these manifestations overlap with some of those of Kawasaki's disease. Now, these children get very sick, and often when they're brought to the emergency room or the hospital, they're found to have a low blood pressure and to be in a state of shock. And they have to get admitted immediately, admitted to the intensive care unit, plugged into intravenous lines, get lots of intravenous fluids. Often they need medications called pressors that are used to raise blood pressure, and we only use in the sickest children. The good news is that most of them respond to this treatment and spend 2 or 3 days in the ICU and then get better and recover overall quickly. A minority of the cases don't recover so quickly, and we've had cases that spend weeks or even longer in the intensive care unit or going on what's called ECMO, which is extracorporeal membrane oxygenation. That's an artificial heart lung, and people with COVID, including children with MIS-C, sometimes have to be on that for extended periods of time. But as I said, most cases fortunately do recover. And I've mentioned how common MIS-C is. It's less than 1% of COVID cases in children. So it's not at all common, but it is out there. Now, let's shift our focus and talk about vaccines in children. So the Pfizer vaccine is now approved for use in children 5 years and older. I think the reason that Pfizer keeps getting approved first is they've just been a little bit ahead, and their regulatory operations are smooth, and they get everything together for their FDA applications. But Moderna is also testing its vaccine in children and will most likely become approved over the next few months. The efficacy of the vaccines appears to be every bit as good in children as in older individuals. Now, I just want to remind people, because some people think maybe shortcuts have been taken in developing the vaccines, that tens of thousands of people were in clinical trials of the vaccines. The Pfizer and Moderna clinical trials that led to their emergency use authorization involved more than 70,000 people. Now, the pediatric trials did not involve that many because it was thought that much of what was learned from the big clinical trials in adults would apply to the children. So there were several thousand children in the Pfizer trial, several thousand children in the Moderna trial. And in those trials, as I mentioned, the efficacy of the vaccine appears to be very good, and no new safety concerns whatsoever have emerged. In other words, nothing has happened in the children who've gotten the vaccine that we haven't seen in the adults. And in fact, we haven't seen the severe side effects that I will talk about in a minute. We have not seen them in children. Now, that may be just because the number of children in those clinical trials wasn't that large, and we may see them as more children get vaccinated, hopefully not. Now, the booster is approved for children 18 years and older, or the word that's used is authorized for children 18 years and older. And it was also recently authorized for 16 and 17-year-olds who received the Pfizer primary series. For those 18 and older, including adults, it's approved for people who got any primary series of the vaccine. Now, the CDC recommendation is that all of those over 18 should get the booster at the appropriate time. They use the word should. In other words, they're recommending it for all individuals 18 and over when either 6 months after the mRNA vaccine primary series or 2 months after the J&J vaccine series. Once that has happened, then they should get the booster. For those 16 and 17 years, the wording currently is that they may get the booster. In other words, this would be something that should be decided by the parents and the pediatrician or the physician. Now, what about side effects? In general, as you know, mild to moderate reactions are common. These are things like sore arm, low-grade temperature, headache, muscle aches, some abdominal discomfort, and so forth. These side effects generally last for 1 to 2 days. They may make a person uncomfortable. They rarely, very rarely, require a person to be hospitalized, for example. They are less common in the elderly, and it appears that they may be less common in children because in these trials of the vaccines in children, they did not show up as much as in adults. Now, the rare side effects that I mentioned, and let me mention this is not in children, this is in adults. We've had cases of myocarditis. We've had cases of something called thrombotic thrombocytopenia, which you may remember got a lot of attention a few months ago. These are very severe blood clots that can form. We've had the Guillain-Barré syndrome or paralysis. We've had anaphylaxis, which is very severe allergic reactions. The good news is that all of these are very rare, occurring in only 1 in 25,000 or even less often than that. Probably the thrombotic thrombocytopenia, more like 1 in 500,000 individuals who gets the vaccine. Now, I do want to say a little bit more about myocarditis because that one uniquely has occurred in younger individuals. So what is it that we mean by myocarditis? By that, we mean an inflammation of the heart. The myocardium is the middle layer of the heart where the muscle of the heart is, and it can become inflamed, and that's myocarditis. This can occur following mRNA vaccines, especially after the second dose, and we know that it occurs more often after the Moderna vaccine than the Pfizer vaccine, possibly because the Moderna vaccine has actually a larger amount of the mRNA in it than the Pfizer vaccine does. This reaction, myocarditis, occurs most commonly in adolescents and young adults. So older adults don't get it very often, and it hasn't been seen in young children to date. And it does occur more in males than in females by a pretty good margin. Most of the cases have been hospitalized, generally just for 1 to 3 days. Myocarditis appears to resolve, and the cases seem to recover, sometimes very quickly. And it's very important to recognize that myocarditis is also something that occurs in COVID. It occurs much more commonly in COVID than after the vaccine. And when the CDC and other experts have done the calculations, what's your chance of getting COVID and what's your chance of getting myocarditis? If you get the vaccine, what's your chance of getting myocarditis from that? The balance is strongly in favor of getting the vaccine. You're less likely to get myocarditis if you get the mRNA vaccine than if you don't and become infected with SARS-CoV-2 and develop COVID. So myocarditis is out there. It's a concern, but it's something that I think we have to keep in perspective and recognize that the choice to not get the vaccine is taking on more risk of myocarditis than the choice of getting the vaccine. Now, Omicron. This virus just keeps throwing new curveballs at us, and this is certainly one of them. Omicron, which I'm sure you all know, is a new variant recently discovered in South Africa, and it contains an unprecedented number of mutations in the virus, more than 50 mutations, many of which are in the spike protein. And that's of concern because if the spike protein changes too much, then this virus may not be recognized by the antibodies that people have made, either because they had an infection or had a vaccine, and the virus may evade that immunity. And we can see that that happens. I'll get to that in a minute. We've now seen Omicron show up in many countries, including the United States, of course. We've found it in more than 40 people to date in at least 22 states. And somewhat disturbingly, about 3/4 of the cases in the US had been vaccinated, and about 1/3 of them had even had a booster. We can see from what's going on in South Africa and also from what's going on in the UK that this virus spreads very rapidly. And this has been a repeating theme. When the Alpha variant appeared first in the UK and then in the US, we found that it spread faster than the original Wuhan strain of SARS-CoV-2. And when Delta came along, Delta spread faster. And the previous versions were already quite contagious, but Delta was even more contagious. And we saw it rapidly take over the COVID scene in the United States and every place else. And now Omicron seems to be 1.5 to 2 times more transmissible than Delta. And it appears that it may be taking over from Delta in some of the other countries. Too early to say, but that is looking like what may be happening in South Africa. So some of the mutations in this virus give it the ability to be very effectively transmitted. Now, the one bit of good news in this story is that the disease may be somewhat milder than the COVID that we were familiar with. It's too early to be sure about this, but that seems to be the early indication. That's what some of the infectious disease experts in South Africa are saying and writing. So let's hope that that turns out to be the case. We have seen already that reinfections are occurring, that having had COVID before does not seem to provide good immunity against Omicron. And there may be some escape from the vaccine immunity. It appears when people look at this in the laboratory that the antibodies that are made in response to the vaccine don't have as good an activity against Omicron as they do against Delta, but they still do have some activity. And what's encouraging is that when people get a boost, the antibody levels go way up, and they do provide what appears to be a protective level against Omicron. So we're hoping, and it's really mostly a hope at this point, that getting a booster will provide protection against Omicron. And I do strongly encourage people who are ready for a booster, because the appropriate time has elapsed from their primary series, to do it, and to do it as soon as possible, because this variant, first of all, it's very helpful for Delta as well, but in addition, Omicron may start spreading rapidly, and we don't really know yet what the consequences of that are going to be. So I think that's the last of the slides. So I hope that material has been informative. And now let's open it up to questions. Fire away.
Okay, thanks, Dad. Well, that was great. So I do have a number of questions that were submitted prior to the program, and I'll go ahead and start with those. And then for anybody who joined us after the beginning, just for housekeeping, you can submit questions now or anytime through the remainder of the program through the chat and Q&A functions, and then I can pass them on. Okay, so let's start with a question that came to me by email right after we sent out the invitation for the program. And the question was this: I have heard more than one parent say they won't vaccinate their children who are under age 12 because COVID just isn't so bad for young kids, and they don't want to risk vaccine side effects just for the benefit of the community. In your opinion, have these parents accurately assessed the risk/benefit for their children?
Well, as you've stated it, I would say their analysis is a little bit incomplete. And I want to elaborate on that. I think it's a very important question and a very reasonable question, very reasonable. And we do know that COVID itself is less severe in children than adults. So when we're talking about the perspective of the individual, then there's a little less gain for the child who gets vaccinated than for the adult who gets vaccinated. Let's say it's an adult who's 65 or 70 and has some underlying diseases. That individual benefits tremendously from getting the vaccine, because if that person gets COVID, they're likely to become very sick. If a 7-year-old child gets COVID, and they don't have the underlying diseases or conditions that I talked about, then they're likely to have a milder disease. So the parents are certainly asking an appropriate question: is it really worth it for that child? Now, first, we have to really remember that not every child is in that category. There are a number of children who have the various conditions that I've mentioned. Of course, since I spend my days at a children's hospital, I see these children all the time, and I'm very aware that they're out there. People who have normal children may not be aware of that, but these children are out there. There are many children with a whole variety of often significant diseases who can be very compromised by COVID. But it is also important to recognize that while it's not common, there is a small minority of normal children who get very sick with COVID. Small minority. I'm not saying anything else, but it does happen occasionally. But in addition, that's where the MISC is so important as a consideration, because MISC typically affects the child who does not have underlying conditions. And it can be very severe. Now, it's not common, as I pointed out, but it is out there. And the parent who decides not to give a child immunization has to think, how would I feel if my child gets MIS-C? How am I going to feel when I see my child in the intensive care unit in a state of shock and knowing that I could have prevented that with a vaccine? So that's thing number one. Thing number two, you can't think about this only from your own standpoint. It's a fundamental aspect of immunization, that immunization is something that we do partly for ourselves and partly for our community. It's simple. That's the nature of immunization. We're doing it for ourselves and we're doing it for the community. And no, we don't want to do something that's only for the community that doesn't benefit us at all. But we have to consider both. We can't consider one and not the other. And so it is important to bring that into the equation. If there were a situation where the child did not benefit as an individual and the only benefit was to others, well, that there would be an ethical problem in giving the child that measure. I don't think that's the case with the COVID vaccine. I think there's plenty of benefit for the child. I also want to talk about other situations that I get consulted about. Child gets COVID and it's the day before Thanksgiving and they're about to go to a big family dinner and there are elderly people there, or there are people who have underlying conditions that will be threatened. Child gets COVID, the parent works and has a critical meeting coming up in the next few days, and the parent now has to go in isolation because of exposure to the child. And the parent may get COVID and miss work and so forth. So the child is not an atom in a universe by itself. The child is part of a nexus, a family network, a community network, and you have to think about it in that context. We just had an episode in a school in St. Louis. Some of the people from the school may be on the line, and several children we know are infected, and it's resulting in fortunately, the children are not too sick, but to my knowledge, but it's resulting in some very awkward situations for families. So this is also something that has to be factored in.
Okay, thanks, Dad. Another question that came in was that even when there are parents who want their kids vaccinated, some of them are asking about possible long-term risks of the vaccine. Could you talk a little bit about any potential long-term risk?
Sure. And so, again, a very appropriate question. And of course, the answer is we don't know. The vaccine has only been with us for a short time, and so we don't know what effects might be out there beyond the time frame that the vaccine has been in use. But I will say, as a person who's been in the field of pediatric infectious diseases for a number of decades, that vaccine side effects, and I'm talking about all the vaccines that are in use, which are many different types, vaccine side effects tend to occur in the first couple of weeks after the vaccine. And there are very few instances where side effects from a vaccine show up years later. Very, very few. In fact, I honestly can't remember ever seeing a case like that was related to any existing vaccine that showed up more than a month after the vaccine. So what is my assessment of the likelihood as an experienced pediatric infectious disease specialist? My assessment is that it's not likely that there'll be long-term effects, but I would certainly admit that it's an open question. But once again, we must be balanced in thinking about this thing, and we must ask the same question in relation to COVID. What are the long-term effects of COVID? And I would be much, much more concerned about long-term effects of COVID, even an asymptomatic case of COVID, than I am about the vaccine. COVID goes around the body, it gets into many cells, it produces inflammation throughout the body. What the effects of that are going to be in the long term, we don't know yet. We do know there's such a thing as long COVID, that these are chronic symptoms that people sometimes get after a case of COVID that may last for weeks or even many months. We do know that children can get long COVID. So if we're concerned about long-term effects from the vaccine, we have to be balanced and think about possible long-term effects from COVID as well, and really be smart. What is the sensible, smart approach here? And when you balance there are uncertainties, as the rabbi said, there are uncertainties on both sides of the equation. We have to be smart about how we assess the significance of those uncertainties.
Mhm. Thanks, Dad. A question has come in from the audience. We are, as you say, dealing with this in real time. And so some of it we're learning as we go. And this question is asking, will the CDC release more safety data for the children's vaccines beyond that of the clinical trials now that millions of children have been vaccinated?
Great question. And the answer is a strong yes. It'll be in addition to the CDC, the FDA. And the FDA has become very sensitive to something called post-licensure surveillance. Now, these vaccines actually technically are not licensed yet. They have emergency use authorization, but absolutely surveillance is in place to try to monitor for side effects that may occur after the clinical trials. Because even when you have clinical trials with 70,000 people in them, if there's a side effect that occurs 1 in 100,000, it may not show up in the clinical trial. But then once a product like a vaccine or a new drug is released and millions of people take it, then certain side effects, more rare side effects, may show up. So yes, there is a strong commitment and mechanisms in place by FDA and CDC and the medical community in general to monitor for additional side effects.
Mm-hmm. So, you talked a little bit about Omicron, and somebody has asked, should children under 12 get vaccinated given that Omicron seems to evade the protection offered by the current vaccines?
Yeah, good question. We think, but it's think and not know at this point, that if you get the primary series of vaccines, that if you then experience Omicron, you may get infected, but we're hoping that, as is the case for Delta, the fact that you got immunized may prevent you from having the more severe version of the infection. Time will tell about that. That's certainly the hope. And then we do have laboratory evidence that once people get to the point where they can get a booster and they get that additional shot, then the level of immunity seems to go up to the point where it seems to be probably more effective against Omicron.
Do you think there will be a booster for kids under 16? And if so, any sense of the timeline?
Yeah, it's just speculation. The children in the clinical trials seem to have a very nice response. It's possible that they won't require a booster, but it certainly wouldn't surprise me if they do. And in that case, the recommendation for the booster will be expanded to include children. But I think it's too early to tell right now, but it shouldn't surprise us if that turns out to be the case.
Mm-hmm. So Dad, a question that came in from a New York City pediatrician had to do with dosing, specifically the lower dose for the younger kids and how they arrived at this dosage. The pediatrician said that parents often ask why the dosing is based on age and not weight, and said that she understands that it has to do with the better immune response with the younger kids, but is the cutoff somewhat arbitrary?
Well, I would say traditionally, the dose of vaccines are selected according to age rather than body weight. We don't typically measure out vaccines in proportion to the size of a child, for example, or big adult versus small adult. It is based more on the maturity of the immune system. So I think that's probably the main reason. And it does create some funny situations. We had the occasion recently of a 35-pound adult who had severe medical conditions, chromosomal abnormalities, and we sought out expert opinion about whether that person should get a pediatric dose or an adult dose, and the recommendation was an adult dose because the person did have the mature immune system of a 35-year-old. So I think that's the reason, but I don't know that we've done careful studies either to evaluate the effect of different doses of the vaccine.
Yeah. Dad, has the data given any indication what role younger kids are playing in the new surges of COVID?
I think there is some concern that both in the US and in other countries, that children may be playing a bigger role than previously. In the earlier part of the COVID epidemic, let's just talk about the US right now, most of the action seemed to be in adults, and children tended to get infected when it was introduced into the household by an adult. And that was actually resulted in many more infections than infections in school. But now, and I don't fully know the reasons for this, as I mentioned, the proportion of cases that are children is higher than it used to be. We are seeing quite a bit of spread among children and more instances where children introduce the infection into the household and then other people secondarily become infected. So I think the answer is yes, that children probably are playing a more important role in the overall epidemiology and spread of this outbreak right now. And we certainly see that in some other countries, including some of the developing countries, where children appear to be playing a very important role in the spread. Now, this should not surprise us because most viral infections actually work that way. They tend to spread readily among children and then come into older individuals as a result of the spread among children.
In that same vein, is there any sense from the CDC when they will authorize a vaccine for children under 5?
Yes, those clinical trials are underway, and my hunch is that it will just be some months before the trials are even going down to as young as 6 months. So I think it may only be in a matter of months before the vaccine recommendation is extended. But of course, it'll depend on the outcome of the clinical trials.
Okay. So I have several more questions, if you don't mind taking a few more. Some of these are very practical questions. Somebody asked if they should space their COVID shot and their flu shot.
No, it's been found that the COVID shot and the flu shot can be given simultaneously, and both vaccines are still effective. So I wouldn't hesitate to get them both at the same time.
Okay. Is there an expectation of a big flu epidemic this year?
COVID has really caused so many different changes in our life, and actually in the life of viruses. So last year, many of the usual viruses during the winter really didn't occur the way they usually do, probably because of all the precautions that we were taking to prevent COVID. And in the case of influenza, for example, there really was no influenza season last year. Now we are seeing some influenza, but I don't think anybody really knows what to predict. There is a concern that it might be a larger than usual influenza season because people didn't have the opportunity to see the virus last winter. But I just don't think we know. Some of the other viruses are also acting in very unusual ways. And so I think we just have to keep our eyes open and be ready to react as we need to.
Okay. Dad, this is actually my question, but I was wondering if you could just talk a little bit in terms of the big picture or to give us some historical perspective, what distinguishes the COVID epidemic from other pandemics in history and from other flu epidemics?
Well, the truth is that I don't think in modern medical history we've seen another example of a respiratory virus like this coming into the population. So I think it's really beyond anybody's experience. But the closest is probably influenza. And if we go back to 1918, the Spanish flu, that was a new strain of influenza. And we knew influenza was around before that, but it was different strains. This was a new strain, somehow came into the human population in 1918 and caused a worldwide pandemic comparable to what we're seeing with COVID. The virus lasted, that pandemic lasted for 2, even into the 3rd year. Then it dwindled down. But that virus and viruses derived from it stayed in the human population until 1957, when they were replaced by the so-called Asian flu strain. And then the Spanish flu strains disappeared, but they reappeared some years later. Again, we don't know exactly why. The other flu example is the 2009 pandemic that you may remember. And that one came in a big way in 2009, and it caused a pandemic that year, It's settled down. It was not as severe as COVID or the 1918 flu pandemic. It caused significant problems, but then it settled down and it's still with us. So that virus is still circulating. My suspicion from the ability that we've seen of SARS-CoV-2 to change is that this virus is probably, unfortunately, going to be with us for a while. But maybe it will evolve to a milder form. Maybe that's what Omicron is showing us, but time will tell.
So no real hope that it'll just burn out and disappear.
I think that's not totally impossible, but I don't think we can make predictions right now.
Yeah. Dad, we have a great question from a mom who's asking if you can give any guidance on how to address children younger than 2 who still can't get boosters or wear masks. She's asking, are indoor classes, shared indoor playrooms advisable? And do we see those being off limits as a real likelihood of returning? Or a real likelihood of returning, excuse me.
Yeah, okay. First thing is to build up a wall of immunity around that child. So everybody who has contact with the child, particularly I'm thinking of the household contacts, who is eligible for the vaccine should get the vaccine.
Mhm.
That way, if the child does become infected, hopefully it won't spread to other people. And then here, again, is this a normal child or a not normal child? If it's a normal child, chances are it's going to weather the COVID infection. If it's a not normal child, that may not be the case. And then I really think you just have to do what you can, recognize that the more people you're around, the more likelihood there is of transmission. And if you're around people who take precautions, the likelihood is less. If you're around people who don't take precautions and who aren't vaccinated and aren't wearing masks, there's going to be more chance of transmission. And of course, the more other children in the pre-vaccine age that the child is exposed to, the more the chances are of the child becoming infected. But I think all of these things need to be weighed. People have their own risk tolerances, and they have to make ultimately a personal decision on this spectrum of where they want to be in terms of risk and limiting their activities, and find the balance that seems to be right for them.
Mhm. Are you thinking it's still okay to do things like travel, or, Broadway has opened up again? Is it proof of vaccination is required, but you're still sitting in a fairly tight space for a few hours with a lot of people? Are these things okay? Or do people just have a false sense of comfort?
Well, I think the vaccine makes a very, very large difference. And that's why things are opening up in the way they are, that people can protect themselves. Hopefully, Omicron won't completely change that equation. But let's talk about pre-Omicron. People could get good protection from the vaccine, particularly if they got a booster. And the places like Broadway theaters are being very strict about implementing additional precautions, such as making sure that people are vaccinated, improving their ventilation, and a whole series of things. And I think that is all part of an effort to try to learn how to live with this virus. And I think that's important. I don't think we can all be holed up as hermits in our houses and apartments. But on the other hand, we have to be careful, be concerned what is an individual's risk tolerance. Can the person protect themselves by becoming immunized or not, and take it from there.
Okay, thanks, Ed. Well, as the hour comes to an end, we'll maybe just do one last question and then we'll close. And the question that was asked was if you could just speak a little bit about people who've had COVID subsequently developing other ailments related to heart, lungs, other kinds of things. Not necessarily long COVID, but just increased risk of other problems after a COVID diagnosis or illness.
Yeah, well, this is what I was getting at when I mentioned that COVID is a disease that spreads to many parts of the body. And studies are being done, and some have even been published to date, following individuals who had COVID. And these are often done with large databases from insurance companies and so forth, and comparing people who had a diagnosed case of COVID with people matched for them who didn't have COVID, and then seeing what their health experience is in the 6 months or a year following that illness. And the findings are somewhat disturbing, that the fatality rate is higher in the people who had COVID. The chance that they're going to see a physician for a heart problem or a lung problem that they may or may not have been seeing the physician for before is higher in the people who had COVID than the people who don't. So there are consequences to having COVID that we don't fully understand at this point, and all the more reason why I do think it's so urgent for us to do everything we can to try to get this under as best control as we can.
Okay. Well, Dad, thank you so much. As always, this was just very, very informative. We're so honored that you could join us and really grateful to you for serving as such a great resource for the community and for so many others. And with that, our president, Jacob Gold, is on the line and also just wanted to say a quick word.
Okay.
Dr. Storch, we can't thank you enough for always being there for our community. And I know Rachel is in touch with you sometimes daily as things arise. So I wanted to publicly thank you not only for Rachel, but for all your efforts in helping keep our community safe during these difficult times.
It's truly my pleasure to be FFAS, Friend of Fifth Avenue Synagogue.
You're more than a friend. You're family. So that F is family.
Thank you.
But we hope to see you back in the synagogue soon. We miss you.
Thank you.
Okay. Thank you so much. Thank you, Rachel, for
so
tonight.
much.
It was really
Thank you.
wonderful.
Thanks,
Have a good
Dad.
evening. Bye-bye.
Bye-bye.
Good night.